Hopefully. Super. So hopefully that started recording for everyone. And then when you're ready, I'll hand over to you, Mohammed.
Hi, everyone. I hope you can see the screen, although it says loading. So let's just try. Can you all see the slides there?
Yes, we can see them.
Okay, fantastic. So, hello guys, welcome to the talk on psychiatry. So my name's Mohammed Qureshi, and I'm a psychiatrist working in Leicester, which means I can basically read everyone's mind, or not. Actually, that's the common myth. But I can't read minds. But what my job is as a psychiatrist, what I see it as, is that every individual that I see, I want to make sure that they can be the most content, successful, and confident people that they're capable of being. My specialty is exceptionally interesting, and I'm hopefully going to try and motivate you guys into perhaps a future career in psychiatry, or certainly in mental health services, because other than psychiatry, there's a lot of different areas within mental health. Psychiatrists are primarily doctors, but there are other areas. There's nursing, there's pharmacists that are specifically interested in psychiatry, occupational therapists. There's all kinds of different professions, psychologists. So hopefully I'll motivate you into that. So just a bit of a background, so overview of what we're going to do today. So I'm going to give a bit of a background about myself, why I chose psychiatry, and then we'll go into some interesting cases that I've seen, and we'll try and make it interactive in terms of the group chat that we've got, and we'll talk about sort of management of certain mental health conditions as well, and then we'll open the floor for Q&A as well. Okay, so actually the first thing I'd like to say is that one of the first things I picked up by all of you guys attending, it's really very, very good to see so many of you here. I mean, there's 100 and 124, 125, the number keeps going up, participants. And this really is a good recipe for success for you guys, because clearly you've shown a lot of discipline to be here. You've taken time out of your schedule to be here. You're clearly motivated. And this really holds you guys in good stead. So keep up the hard work. It's very, very good to see. So a bit of a background about myself. And as a psychiatrist, we get to spend loads of time with patients. As one of the best things about psychiatry, you can really build that connection with your patients. You spend around half an hour to an hour with each of the patients that you see, versus like a doctor in general practice, for example, only gets about 10-15 minutes with a patient. So you really spend your time listening and learning from your patients. So we have to ask a lot of questions as psychiatrists, and we're often quite nosy, and we have to be quite curious individuals. And so I think it's only fair that I give some information about myself as well, as a psychiatrist. So I was born and brought up in Lincoln, in the East Midlands of England, and I pretty much just powered through school and university. So I didn't take any gap years, I didn't take any breaks. And I went to the University of Leicester to study medicine, which is a 5-year course. And then after that, I still stayed in the East Midlands. And once you become a doctor after the 5 years, you have to rotate around different specialties. And maybe some of you will ask about that in the Q&A in terms of the route to becoming a psychiatrist. And we can cover more ground there. But you have to rotate around different specialties. I stayed within the East Midlands. And now I've been specializing in psychiatry for about 5-6 years now. So I'm reasonably experienced. And I'm something called a registrar, which is one level before a consultant doctor, which is the highest level. So that's just a little bit of a background about myself. Live in Leicester as well. Really interested in sports. It's one of my big passions. I'm a big tennis player. That's just a little bit about me. So let's just go into a little bit about why I chose psychiatry. So the first reason that I think I was suited towards psychiatry was my own personality. So I found that growing up, and some of you might relate to this, I was more interested in people than I was in things. things. And I think there are two kinds of individuals in the world, those who are interested in people and those who are interested in things. There's sometimes a little bit of an overlap, but those people who are interested in things or objects or items, they tend to go into areas such as, engineering, technology, things like plumbing, those kinds of areas. But people who are interested in people tend to go into these kind of specialties like, medicine, healthcare, teaching, those kind of areas. So I found that my personality growing up, I was more interested in situations and people, what made people tick, what aggravated people and rubbed them the wrong way. And I also found that I was very interested in things like detective shows and piecing puzzles together, which is very much what we have to do as psychiatrists. The patients that we see have many, many different problems in their life. And it's all part of a jigsaw puzzle that we have to help the patient piece together. And it's not necessarily for us as psychiatrists to complete the puzzle for them, but we want to facilitate them to identify those pieces, how the pieces interact with one another, and try and come to a solution to their problems. And that's life, isn't it? Like, you've got lots of different areas in your life, lots of different departments. For you guys, you've got school, you're thinking about exams, you've got relationships, thinking about you're kind of at the age where you're just kind of forming your identity more and more. You've got your family relationships, you've got your time outside education, and all of these things kind of come together. And I'll give you an example. If I'm stressed at work, there's conflict at work, it might rub off in different areas of my life. So I might be threatened with being fired, and then there's concerns about my finances. It might aggravate me more, make me more irritable, and that might affect my relationships with my family. I might not have interest for things outside of work, my hobbies, because I'm just so stressed about work. So these are like, it's like a jigsaw puzzle, and if there's one problem, it might have a knock-on effect on other areas of your life. So it's about kind of piecing things together, very much like a detective, and that's what I found interesting. And psychiatry is very much suited to that kind of personality, and indeed all healthcare is very much suited to those kind of personality traits. But the interesting thing is that you need both of these kind of people. You need people who are interested in other people, and you need people who are interested in things. Like, I had a plumbing issue a few months ago, and I had to hire a plumber. I had a leaky pipe, and if you go to places like Silicon Valley in America, where like kind of technological capital, you need those individuals that are more interested in objects and figuring things out. You need that balance in society. As with everything in society, you need that balance. Another reason why I was quite interested in psychiatry was I felt really valued as a medical student, more so than I did in any other specialty. And in fact, I felt that when I spoke to patients, the psychiatrists were really, really keen to hear back from me in terms of what my view was of the patient. And sometimes I felt that my views were consequential in kind of decision making. So for example, psychiatrists, we get lots of time with patients, but sometimes as a medical student, you've got even more time, and you can unearth things and find out things that maybe the psychiatrist or the team haven't found out yet. And so when I spoke to certain patients and I found out things that the psychiatrist hadn't found out, they were really, really grateful for that. And it helped them make certain decisions about patients. So I felt really, really valued. And not only that, the psychiatrists that I worked with, and indeed pretty much unanimously, all the psychiatrists that I've worked with, they've got really, really nice personalities. I'm probably quite biased here, but really, really empathic. And obviously you have to be, people are coming to you with all kinds of problems, all kinds of traumas within their life. And you really need to have an empathic approach. I remember, Rachel probably knows about this consultant who works with patients who have dementia. And she was literally the most compassionate doctor I've ever seen. During the ward rounds, when you see the patients, she was feeding. She had some cookies there, and she was feeding the patients, really, really caring, treating them as an individual. And I found that really, really inspirational. As I've already alluded to, I find this specialty very, very fascinating, trying to identify all the problems that an individual was faced with, all the stresses, and trying to help them kind of come to solutions for their problems. I find that really rewarding. And there's nothing more rewarding than walking into a room where an individual is kind of at the end of their tether, maybe don't even want to be around anymore, don't want to be alive. And by the end of the consultation, you spent a good half an hour to an hour with them, and they walk out of the room with a new lease of life, with more hope instilled within them. There's nothing more rewarding than that. I also find that I learn quite a bit from my patients. Like I said, we spend so much time with them that you're bound to learn from your patients. You've got the opportunity to do so. And not only do I learn about the world, but I learn life lessons as well. As it pertains to learning about the world, I remember one of my patients who was suffering with some memory problems. They were over the age of 65, had a lot of life experience, but I was asking them about work and what they used to do in the past. And one of them said that he was an ornithologist. I don't know if any of you guys know what an ornithologist is. You can just share it in the chat if you do. Any takers? Can't see any comments there. Hazard a guess. They look into a certain kind of animal. It's a study of a certain kind of animal. Ooh, is the chat disabled?
Yeah, I think it's not. Well, I apologise. Yeah, the chat's not been set up properly, but you can still type it in the Q&A, and that's fine. And we can use that, and I'll just dismiss the comments. Don't worry, guys. You can comment on the Q&A if you've got ideas, and I'll delete the comments. Sorry.
Oh, yes, excellent. Chondriana, that's a really cool name. Birds, yeah, absolutely. So it's the study of birds. So that you just learn about the world. And so ornithophobia is a phobia of birds, which is actually more common than you'd think. One of my wife's uncles, he's terrified of pigeons. We speculate as a family that maybe he was pooed on by a pigeon or something when he was younger, but he's quite guarded about that. But so I had a Sikh patient a few weeks ago who was very, very anxious, very, very, very depressed. And he was telling me about some voluntary work he does in a Gurdwara, which is a Sikh kind of temple, place of worship. And he had a very specific role within that Gurdwara where he would deal with, they have kitchens within the Gurdwara, and every day they feed people who are hungry. And I didn't really know about that. And I got speaking to him, learned more about it. Fascinating stuff. So you really learn from your patients, but you also learn life lessons. So I had a lady who again was very anxious, really struggling, not looking after herself, very low in mood. And she came back to me a little bit later and was feeling a bit better. And she herself had identified that she hadn't been looking after herself. And she was somebody that very much prided herself on her appearance. And she found that she went out to buy some new clothes. She just looked after herself, made sure she was washed for a few days consistently, wearing makeup, sorting her hair out, whatever it may be. And she just started feeling more confident in herself. And she identified that she was so focused on looking after other people that she had forgotten about herself. And the lesson that was gained from that was that we need to look after ourselves first before we can look after other people, right? And so I found that very, very interesting. So you learn a lot from your patients. You learn about the world as well, as I mentioned, even things like popular culture, right? So books that you read or movies that you watch, because as a psychiatrist, you kind of train in psychotherapy as well and psychoanalysis. And so you find out interesting things about, you find interesting trends and patterns within popular culture as well. So for example, I don't know if any of you are big fans of Harry Potter, but I was a huge fan of Harry Potter growing up. And even reading into Harry Potter, you learn lessons from that, interesting things that I don't think I would have gathered if I wasn't a psychiatrist. But for example, who's the arch nemesis in for Harry Potter in that franchise? You guys know? Just type it in the Q&A. The Malfoys, right? Yeah, so it's Voldemort. Yeah, that's a clever answer, Abdul. Yeah, Draco is a bit of a nemesis for Harry, but the arch nemesis, the main villain, is Voldemort, and they often refer to him as "he who must not be named," right, to begin with. And I got thinking about that, and we see people with phobias all of the time, and those individuals are very avoidant of that specific situation. So if you've got a phobia of elevators, or you've got a fear of heights, you do all that you can to try and avoid that situation. And merely the thought of that situation brings a lot of anxiety to the individual. It's something that's known as anticipatory anxiety. So and the cure for phobias is to face up to that feared situation in controlled steps, and you find that you're tougher than you thought you were. And it's similar in Harry Potter, that they're so fearful of Voldemort that they don't even want to name him. They want to avoid naming him. And so that's really, really fascinating. Another thing about Harry himself is that he's a flawed character, right? He's the hero, but he's a flawed character. And this is us in life as well. We're flawed characters, whether we know it or not. We want to be perfect individuals, but we're not. We've got, we get irritable, we get angry, we have days where we're upset, we sometimes have bad thoughts, perhaps. And it's important to know that, and it's important to know that we've got that capability within us to have a darker side to us, because we're more watchful and careful in the future, right? We're careful in relationships, we're careful about what we say. So it's really important to know that. So Harry Potter is a flawed character, but he overcomes that in order to be the hero. And you see that also in other areas as well. I don't know if any of you are fans of comics and superheroes, but a lot of superheroes are completely flawed, like Batman, for example. He's got a much darker side to him, but he overcomes that, and that's what makes him the true hero. I was watching, as psychiatrists are very normal, I was watching Shrek the other day as well, and he's far from the perfect character, gets angry all the time, but he's still the hero of the story because he overcomes that. So you find really cool things about, that you see around you in popular culture and stuff, that you can derive lessons from, that I wouldn't have been able to do if I wasn't a psychiatrist. You learn valuable skills about everyday life as well, like in terms of communication, for example. We have to communicate very clearly, very precisely with our patients. And if we don't do that, then it's going to be a struggle for us as a psychiatrist. But we learn to refine that skill. We learn time management, how to negotiate with patients, which is really valuable in everyday life, right? You need to be able to negotiate day to day. Sometimes you have to negotiate with your spouse or your loved ones. If you're going to buy a car, you need to negotiate with a salesperson, or if you're buying a house. And I developed those skills through being a psychiatrist, more so than I think I would have done with any other specialty. So that's another really cool thing about psychiatry. And not only do I want to develop myself as an individual, but you also need to think about, that work-life balance as well, and how you spend time with your family and so on. And psychiatry is an area where you do have a really nice work-life balance. The on-call shifts aren't overly taxing. I myself actually can do on-call shifts from home and go out only when I'm needed to go out, rather than being there all the time. So really nice work-life balance. And the process of getting into psychiatry as well is less taxing than other medical specialties. So you become a doctor, then you have to start specializing, whether that be in psychiatry or lungs or the heart, wherever that area may be. And so for psychiatry, the pathway isn't as long, and so that was a real bonus as well. So the combination of all of these factors really make me want to promote psychiatry to you guys, and hopefully motivate you into a career in this fascinating area. Okie doke, fantastic. So moving on. Oh, hopefully I think you just got the answer there, but if you had quick vision. But so what sort of cases do you guys think that we see in psychiatry? Just type away in the Q&A. What type of I'll give you, well, actually no, I'm not going to give you any clues. I'm not that nice.
Anxiety and depression, OCD,
Fantastic.
schizophrenia, dementia, depression.
Absolutely fantastic. So yeah, all kinds of different things. That's another cool thing about psychiatry. You see even one individual, or even or a selection of individuals with depression, you get 10 people with depression in front of you. Their depression may manifest in different ways. So it's not like a blanket presentation for all cases of depression, right? You might get some people that struggle to, that wake up really early in the morning. You might get somebody else that really struggles to get to, get off to sleep. You might get people that aren't eating and drinking. You might get suicidal patients. You might get people that are overthinking and really, really negative, feeling guilty or ashamed of something. People present in so many different ways, which is one of the really, really fascinating areas of psychiatry. And one of the other reasons I was really interested in mental health was that I was just fascinated by the mind, right? Like we all struggle with our mental health. We don't necessarily all have depression or anxiety that's diagnosable and can be treated with medications, but we all struggle with our mental health. We all need support from our family and friends, right? When we're struggling in terms of feeling upset, for example, or if we're feeling irritable, or if we're feeling anxious about something, we've all felt that. We've all felt stressed, right? And we're all seeking help for our mental health, whether we know it or not. And so that's one of the big reasons why one of my main passions is trying to break down kind of the stigma around mental health, because it's just as, if not more important than one's physical health as well. And it's strange, right? How we have control over our body to a certain degree. We can control what we do with our arms. I can wave my arms around like this. I could get up and run around the room, but I'm not going to do that because I have control over that. But actually, our minds, we have much less control over, right? The average human being spends about 80% of the day worrying. And if you think about yourselves as well, even you guys probably overthink about whether people like you, what the future holds for you, the stress of exams, the worry about your family dynamics. You're constantly overthinking these things, so even at the best of times, we're overthinking, right? And so psychiatry has kind of helped me to work on that myself as well, so that I'm more in the moment and more grateful for kind of what I have, and more mindful. So I'm not going to run around the room and take my top off and run around the room because I have control over my body. But the mind is much more fascinating. So this case was one that I saw several months ago. He was a 69-year-old man. He had a 6-week decline in his mental health. So 6 over 52 means 6 weeks. As doctors, we use a lot of abbreviations. So because it's 52 weeks in the year, 6 over 52 is 6 weeks. And he came in and he was very, very suspicious towards his neighbors. He felt that they were deliberately aggravating him. They were controlling his TV volume somehow. He was convinced that this was the case, that they were controlling the volume on his TV. They were using electrical devices to spy on him, so much so that he was making holes in his plasterboard, in the walls of his house, trying to identify these cameras. He didn't find any cameras, but he was still convinced. He very fascinated. He was very interested in this technological side of things and the neighbor's role in that, so much so that he wrapped all the electrical device in his house in tin foil and actually threw them outside as well, because he didn't want them within his house. He disposed of his PIN numbers, and he didn't just think it was one set of neighbors. He thought the whole community was collaborating against him. He said that his neighbors kind of he could hear his neighbors through the walls and things, although he didn't even live in a terraced or semi-detached house. He lived in a detached house. And he was hearing the voices of his neighbors talking about him. And there's something called running commentary, which is a type of what we call hallucination, which is, for example, hearing voices can be a kind of hallucination. It's not actually happening, but the patient is convinced that it's happening. There's a special kind of what we call auditory hallucination, where they hear people telling them exactly what they're doing. So, for example, Mohammed is picking up his glass. Mohammed is taking a sip of his water. It's a very specific type of hallucination. So, and when he spoke to this guy, he was really distressed when talking about all of this stuff. And it culminating in him saying that, initially when he spoke to him, he was okay, but when you scratched under the surface, he started getting more and more paranoid as he spoke to him. And it all culminated with him believing that, the bomb disposal squad were called because he had a bomb that had been planted in his loft. So needless to say, this chap, he didn't have any insight into his mental health problems, and he needed to be brought into hospital. But what do you think this individual could have been suffering with? What kind of condition? Schizophrenia, and John said schizophrenia. Excellent answer. And so, yeah, we think he was suffering with schizophrenia, which is a type of psychosis where psychosis is defined as an altered reality for the individual. So they're not in touch with reality, and they're convinced that things are happening, or that they're hearing things or seeing things that aren't actually happening. I was on call actually last night, so a little bit sleep deprived, which is probably why I appear a little bit manic. But so I saw a patient yesterday who was also psychotic, and what she'd been doing is she'd gone to this random neighborhood, and she it's unclear why she went there, and the residents of that neighborhood had alerted the police that this woman had been behaving quite bizarrely and just standing there looking into a house that had no significance for her. She was looking into the house for 4 hours, just standing there. And so the police had to be called, and then she was behaving quite bizarrely with them, quite vacant. And then when we spoke to her, it was just impossible to follow her. She had something called thought disorder, where the thoughts are not clear, and she is not able to express what she's thinking. And she was all over the place and very, very unwell, and we had to bring her into hospital. But yeah, in this particular case, this man had schizophrenia, and just as with depression, no two schizophrenias are the same. I've seen people present in all kinds of different ways with schizophrenia, and people who've got think they've had chips put into their mind, that they're being tracked, and so on and so forth. So there's lots of different ways it can present. What kind of treatment do you think we could give this individual? Any ideas?
A few things in the chat coming through: the CBT, antipsychotics medication, antipsychotic medication, cognitive behavioral therapy.
Okay, excellent responses. So I guess the first thing that we needed to do is figure out, could there be a reason in terms of his physical health why he might be presenting with these symptoms? Because sometimes we see people who have an infection, or are anemic, or have some problem with their physical health that causes them to be a little bit confused, and they can also be quite paranoid and can hallucinate as well. So we needed to get a set of blood tests from him, and sometimes things like schizophrenia can be caused by inflammation within the brain, and again, blood tests can point in that direction. It's important also to get a scan of the individual's brain as well, because sometimes things like tumors within the brain can cause a change in personality, can cause people to experience voices, and all kinds of different things, actually. So important to rule that out too. So the mainstay of treatment for him would have been antipsychotic medication, because fundamentally, schizophrenia is caused by an imbalance in chemicals within the brain, something specifically called dopamine. And in the brain, there's too much dopamine, and so medication tries to bring that level down, and that can really help with symptoms and the individual's presentation. However, he was refusing medication. So he was in hospital. This guy was in hospital because he was just so distressed in the community, and he wasn't accepting medications at home. So he was brought into the mental health hospital, but he felt that the medication was the incorrect medication. He didn't need it. It was dangerous to him. It would poison him, and there was some fault with the medication where it had been recalled by the manufacturer. This was all part of his psychosis. So we had issues giving him medication. So then this comes down to sort of negotiating and trying to figure out what to do with him. And there are options if he's not accepting tablet medication to give him injection medication as well, instead of the tablet. And sometimes we find that if we give the injection medication, in the future, the patient just accepts the tablets. But you really have to put the patient at the center of their management, right? It's always a balance in medicine. There's multiple ways you can go about it, but you want to ultimately do what's best for the patient. So, giving him an injection may seem quite an aggressive thing to do, but actually the amount of distress that he was in with his paranoia, which wasn't going to get better without medication, you want to administer that medication so that distress reduces. So sometimes it's a case of short-term pain for long-term gain, really, but ultimately you want to do what's best for the patient, and you don't take any decision lightly. And also what we wanted to do is work on that relationship with him, because we didn't want him to become more and more paranoid with us. So, trying to listen to what he was saying. So he wanted to go home to pick certain things up from home. So allowing him to do that and allowing him to have some walk within the hospital and so on. So it's all about developing that relationship with the patient. And particularly when it comes to things like depression and anxiety, you can go a long way by just being there as a support for the patient, being there to listen to the stresses that they have, because often they don't go to their family because for whatever reason they might be feeling guilty, or they don't want to they don't want to stress the family out, or sometimes the family don't even want to listen. So sometimes when we're stressed, we might go to individuals who don't really care, but as medics, where it's ingrained within us to really care and be empathic about the patient, about the individual. So we really wanted to build that relationship with him. And then we continued to monitor him on the ward. We got the medication into him. He developed more insight that something had been wrong before the admission, and then he started taking tablets, got better, and got home, and got home with support as well. Okie doke. So excellent. I hope you found that interesting. I do have some other cases as well, but I think we've got a lot of questions coming in, Sarah, if I'm not mistaken. Shall we move to the Q&A?
Yeah, of course. So I don't know if Rachel's still there and wants to also share some answers as well. Oh, she's here. She's back.
I'm here. I've just been answering all the questions. Lots of great questions, which has been great. No, I mean, I think Mohammed, as always, has covered it really well.
Do you want to quickly introduce yourself?
Yes. Yeah. So I'm Rachel. I am a psychiatrist. I work in liaison psychiatry. So I'm a registrar like Mohammed, but I'm in the final part of my training before becoming a consultant. And I've been working in liaison psychiatry during the pandemic, which has been really interesting. So that means that a liaison psychiatrist is someone essentially who works often in a physical health hospital. So I work at the Royal Infirmary, where there's all the patients on different wards, maybe surgical wards or orthopedic wards, and old age wards. And I go and see patients who are in hospital because of lots of different reasons. Maybe they've had a fall at home, maybe they've got a urine infection, they might be having a complication from a treatment, for example, they might have cancer and they've come into hospital because they're not well. But I go and see them when they also have a mental illness, or their medical or surgical team are worried about them and are about their mental health. So my job is to go and assess their mental health, and sometimes prescribe medications if they need them, or to put plans in place to help them, or sometimes to make sure that they are transferred over to a mental health hospital if that's the best course of action. So it's been really interesting, actually, especially during the pandemic, because we've seen some really difficult cases, some very sad cases, often triggered by loneliness and isolation. And that's been hard. I also teach at the medical school, so I am a lecturer on what's called the foundation year, which hopefully some of you may have heard about, which is a kind of year zero. It's the first year of a 6-year medical degree for students who are from a less advantaged background. And I'm sure Sarah will be able to explain it a lot better. But I teach on there, and I run a very empathy focused curriculum for students who want to become doctors.
Super, thank you. I'm going to go to this question because you semi-touched upon it briefly in your presentation then. So what effect did the lockdowns during the pandemic have on people's mental health?
Well, I think it's had a huge effect on people's mental health. And I suspect Mohammed and I will have kind of seen some cases that have been very similar, but we've probably had quite different experiences too, with different types of patients that we've seen as we work in different areas of psychiatry. So I work with older people, so people over the age of 65. Obviously, a lot of those people have comorbidities that make them more at risk of getting ill from COVID. So particularly in the first half of the lockdown, we saw a lot of older people who were isolating or shielding, were very frightened about getting ill. But actually the toll of being away from their families and not seeing people, not maybe talking to people very often, was really difficult, and has led to patients ending up being suicidal. So older people maybe who've never experienced a mental illness in their life, presenting with very severe depression, where they're not eating, not drinking, not engaging, not able to look after themselves, and that might culminate in them attempting to end their lives, and then coming into hospital if that's not been successful. So that has been very hard. And I think what's been really hard is in psychiatry, one of the things that we do is prescribe medications. That's always part of a management plan. But we also often make sure that patients have networks, that they are plugged into society, really, that they might attend day centres, that they have the opportunity to take part in activities that they enjoy and meet people. And obviously during the pandemic, we've not had any of that. It's all been withdrawn. So part of what we would have done to help them recover from a mental illness would be kind of social activities and engaging with others. We can't do so well. So it's been really hard to make sure that people have stayed well. On the kind of other side of things, and Mohammed's probably seen more of these cases, but when I've worked on call, I've seen quite a lot, particularly again during the earlier stage of the pandemic, of a lot of anxiety disorders becoming very severe, with people maybe becoming so anxious about getting ill from COVID, or so worried about losing their jobs, maybe, that the anxiety and the worry that they have can kind of tip over into what we call a psychotic illness, where they become very paranoid maybe, or start to develop some very delusional beliefs and bizarre kind of ideas about maybe people following them or monitoring them. And that's been difficult, and also lots of conspiracy ideas that have become very toxic for people, and they can't kind of get away from those ideas anymore, and that they make them ill, to the point that sometimes they've needed to be sectioned under mental health law and brought into hospital because they're so ill that they're not able to kind of make decisions for themselves and don't really see how unwell they are.
Super. Do you have anything to add, Mohammed, or should I go on to the next questions? There's quite a few.
Yeah, no, we'll go on to the next one.
Super. I think I'll answer this one because I think it's probably something you want to address, as it's a big stereotype about, do you ever have violent patients?
Yeah, so if you look at society, there'll always be violent individuals, right? And so it goes without saying that within a cohort of patients, even if it wasn't mental health, you'd have some aggressive or angry patients. And so psychiatry is no different in that regard. But what I must say is that 99.99% of our patients are not aggressive, are not violent, and are very, very pleasant, actually, just really struggling and need support and help. So we do see some agitated patients at times, particularly if they're sort of psychotic and paranoid, and this is like very, very few patients. But if they are paranoid, they might think that we're conspiring against them, might become quite agitated and aggressive. I think one incident that happened with me was we're just in we were just in a ward round, and I was just making some notes, and it wasn't a psychotic patient, actually. It was an individual who just had a very, very difficult life, and just was making some bad decisions because of the traumas that had happened in her life. And she got very agitated, and for some bizarre reason, next to where she was sat, there was a plant pot. And so she just picked up the plant pot and threw it. And it always happened in slow motion, where it just hurling through the air and hit me squarely in the chest. And that was a really interesting experience. But she was very apologetic about it afterwards, and she'd been quite agitated for a number of reasons. But that's maybe one or two incidents in 5 years where there's been some aggression. In that case, it wasn't even directed at me. I just happened to be an unfortunate victim.
Yeah, I'd probably just add that I've worked in psychiatry for nearly 10 years, I think, or maybe over 10 years now. And I've very rarely felt threatened by patients. Before I trained in psychiatry, I worked in A&E for a year. And I think that's probably more the general public with all sorts of health problems are probably more risky. But also as psychiatrists, we have lots of training on how to engage patients appropriately. So patients who are agitated and distressed, we know how to disarm them, how to talk to them calmly, how to control the situation. And we have lots of safety measures in place to see patients together. So if you're worried about a patient, you see them with other people. And there's a lot of setup on the wards and in communities to make sure that you are safe, so we don't take risks.
Thank you. I'm going to probably hand this question to you, Rachel. So what's the difference between a psychiatrist and a psychologist?
Okay, so this is like, so I'll start with saying, essentially, a psychiatrist is a medical doctor. So a psychiatrist has been to medical school, they've been a foundation year doctor, they've done everything that all junior doctors do, and then they choose to train as a psychiatrist. So you cannot be a psychiatrist if you have not been to medical school and graduated as a doctor and then been through your psychiatry training. Psychiatrists work with patients in a whole range of settings. There are lots of different types of psychiatrists. So there's old age psychiatrists and adult psychiatrists, child psychiatrists, psychiatrists who work in forensics or in learning disability, and within those lots of other specialties too. And we generally spend our time seeing, assessing, diagnosing patients and then treating them, and part of that, a big part of that is prescribing medications. But as we're doctors, we're also trained to obviously think about their physical health, because their physical health can impact their mental health, and their mental health can impact their physical health, and the medications that we prescribe can interact with physical health problems and can cause physical health problems. So as psychiatrists, we have to have a really good understanding of the body, how it works, and about disease in general. Psychologists, on the other hand, are doctors of psychology, and they are professionals who have usually undertaken a psychology degree, so usually a 3-year degree at university, and then have decided what type of psychologist they want to be and have gone on to further study to become that. So for example, a clinical psychologist is someone who works with patients in hospital, and they usually do another 3 years of training. So after their degree, they have to apply for a higher degree in psychology and train for another 3 years, and then they become a clinical psychologist, and they will often see patients and work with them, maybe using techniques like cognitive behavior therapy, and help them to manage their mental illness through talking therapy and through counseling like sessions. They're not counselors, they're kind of more senior than that, they're more trained, but they can't prescribe medications. And they don't know much often about kind of other illnesses. They're trained to work specifically with people with mental illness that can be helped by a psychologist. Obviously, psychiatrists and psychologists they're both really interesting jobs, but they're very, very different training routes. So yeah, it's definitely worth having a look if you're not sure what kind of career you want in medicine or psychiatry.
Thank you. I know you touched upon it briefly in your presentation, Mohammed, but another question's come in about the work-life balance, which I think lots of students are really worried about, the work-life balance and separating work and personal life with intense courses like medicine. So I don't know if you can both share your experiences of that.
Yeah, no, absolutely. There can be times in the training process where, particularly in those initial years where you do a lot of on-call shifts and things as you're rotating around different specialties, where it can be tough. If you do a week of nights, for example, then for that week you don't have much of a social life, because during the day you're sleeping and at night, you're working. So I'm not going to sugarcoat that. But as you then progress through the years, things can become easier. But this is why it's important to make the right decision and what's suited to you. Some people manage that even in high pressure environments with difficult hours. Sometimes people manage that and thrive in that, right? So it very much depends on the individual. I suppose the advice that I'd give you is that in psychiatry, if you choose to do so, you won't feel overworked if you manage your time well. And this is the advice that we give to our patients as well, particularly patients that are anxious and stressed. Often, probably you guys have experienced it when you're studying as well, where you wake up on a certain day really motivated to work, and then you go onto social media, and then before you know it, you've clicked loads of things. You're on YouTube clicking on the recommend videos, and you procrastinated, and before you know it, the day's up and you feel hopeless and useless, right? It's happened to all of us at some stage. But if you are able to construct a daily schedule for yourself and stick to that and include things in there that you enjoy as well, then it works out really well for you and you feel more productive. And similarly, that's what I do with my working day as well. So I've got allocated time for my interests, so playing sports or spending time with my family or watching a movie, and that's part of my daily schedule, because it's important to be able to unwind, right, whilst also maintaining that responsibility of work as well. So the key is time management, which you'll develop over your careers. You'll develop and hone in that skill, but work-life balance can very much be achieved, very much so.
Thank you. Sorry, I was frantically trying to answer some questions. Just to clarify, I've got a few questions. So yes, if you want to become a psychiatrist, you do have to study medicine at university. That is the route into becoming a psychiatrist, and that is sadly the only way to become a psychiatrist. And there's a few questions coming about that. Something which I think more looking back probably to when you were at medical school, which I know as lots of the students are thinking about medical school as their next step. When you were in medical school, how did you manage the work-life balance of medical school? So you focused on it after training, but what about when you were at medical school?
Do you want me to answer that? Mohammed's probably been through it more recently, but well, for me, it was about, just as Mohammed said, really about other things. It's really hard. Med school is a real hard slog. I did not find medical school a walk in the park at all, but you have to, it's a marathon, not a sprint. So you have to pace yourself. You have to take time out. You have to work smart, really, and certainly at Leicester Medical School, and I'm sure at other medical schools too, but I know at Leicester Medical School there was a lot of focus on study skills, so teaching you better ways of working, better ways of learning, so that the hours that you put into study are utilized the best that they can, and that allows you to then take more time out for yourself. I think how you manage is by having a good network of friends and colleagues and peers at university who help you get through the difficult times, and you kind of party and have fun when things aren't so hard. I think they're also what's really motivating in medicine, despite it being a really long degree, a 5-year degree that is hard work. You're training to do something that I hope that you want to do. You're not going to be going through medical school unless you really want to be in medicine working as a doctor. So that's really motivating, and it's fascinating. Most of what you are learning is really interesting. Medical schools usually split into kind of, at times when you're in the university, kind of in the medical school, studying, going to lectures, learning about biochemistry and pathophysiology, and doing quite a lot of book work, I guess, or work on computers. But then there's a huge amount of care of learning through patient experiences and being on wards and placements, and it's just so interesting. It changes all the time. There's a huge amount to learn, but it keeps you interested. And if you're not interested, you're probably in the wrong degree. so yeah. So hope that answers the question.
Super, thank you. And this, we touched on it a little bit earlier, but about the impact of the pandemic. But I think some of the students are wanting to know about what they think the general aftermath of the pandemic. So looking about the impact, I guess, longer and more afield about what that's going to maybe mean for psychiatry.
Do you want to take that, Mohammed?
Yeah, sure. I mean, I guess on the question of the pandemic, as Rachel was saying, I've kind of probably had different, every psychiatrist has had different experiences, and I work with more of a kind of a general adult population really at the moment, although I do some old age work as well. And interestingly, initially during the pandemic, some of the patients that I saw that I expected would be very depressed and anxious were doing okay in the initial period. And I think the reason for that was that one of the main drivers, I feel, for anxiety and depression from a psychological standpoint is that we compare ourselves to other people, and we often think that other people have the perfect lives, maybe sometimes because of social media and other things. People don't generally share the bad things in their life, right, on social media. And so you've got this idealized view of the world, and we compare ourselves to that, and we feel unhappy because we haven't achieved that, which is the wrong mindset altogether. But nonetheless, some people at the start of the pandemic realize that actually everyone's in the same boat, everyone's struggling, and that kind of helped them in that initial period. But then as things got more and more protracted, more and more lengthy, then the problem started to emerge more and more. And if you think about it, I've had patients who are single parents, got 2 kids, dealing with them on their own, homeschooling, throw in a child who's got severe autism, throw in some financial difficulties, throw in a bit of alcohol, lack of support from family because of distancing and so forth, then you've got a problem, right? And so as things got more and more lengthy in terms of the duration of the pandemic, things got much tougher. I honestly think that we will see over the next couple of years, I think we'll see more and more, even before the pandemic. I think just because of the awareness that's being raised in terms of mental health, we're seeing more and more patients come through. But I think the pandemic's probably accelerated that process. And we'll see people that are affected by the pandemic for many years to come, because lots of people have lost jobs, they've lost loved ones, they've not grieved properly. They have sometimes seen people in healthcare, sometimes seen very traumatic things and are struggling with PTSD levels of which have gone up. So I think we'll see the shock waves of this for the next couple of years, really. Which is why we need more psychiatrists. So please join the club.
Super, thank you. So I think this is quite maybe a slightly negative question, so we'll do best and worst. So someone's put, what's the hardest thing about being a psychiatrist? But maybe you could complement that with also what's the best thing about being a psychiatrist?
Well, I've kind of typed a short answer to the hardest, but I'll let Mohammed say what his hardest thing is. But for me, the best things, which is obviously good to focus on first, is it's a really fascinating job. You meet really interesting people. I think most people are interested in psychiatry, whether you want to be a psychiatrist or not. Most talking to psychiatrists about the kind of patients they see, because that's life, and it's fascinating. You genuinely could not make up the cases that you see. They are often stranger than fiction, and that to me is just interesting. You also get an opportunity to work with people who are not often don't have many advocates. So obviously, as we all know, there's a lot of stigma still, unfortunately, against people with mental illness, and as a psychiatrist, you have the chance to champion them and support them, and help to change attitudes in society. And you work with people who are at their most vulnerable and ill, and seeing someone whose mind is truly broken is awful, but seeing them get better and knowing that you've played a part in that is incredibly rewarding.
Yeah, I'd echo that. I mean, I usually like my dessert after my vegetables, so I'll give you the tougher thing first. So I didn't see Rachel's comment, but I think for me, obviously, you do hear some difficult things. You know, what you realize as a psychiatrist is just a little bit of scratching on the surface, and everyone's suffered with one or multiple major tragedies in their life. And even if you think about your own lives, there's probably been tragedies in your life where, you know, you've lost loved ones, or something really traumatic has happened to you, or you've been betrayed by a loved one, whatever it may be. So you know, some of the things that we hear about difficult things that have happened in the past to individuals, and how obviously it clearly makes them upset thinking and talking about it, it kind of can rub off on you, and can be very difficult to hear. And so I guess the emotional side from our perspective, it's important for us to look after our own emotional well-being as well. Which can be challenging at times, but as a psychiatrist, you learn to do that really well. We're taught that time and time again going through our training. So we are equipped to deal with that. The best thing, similar to Rachel, is just how rewarding as well as how fascinating it is, how rewarding it is. It's a specialty where you really deal with the patient holistically. So when I say holistically, I mean you look at it from all different angles. Not only do you try and treat any physical health conditions that could be contributing to their mental health problems, you try and think about their thought processes as well, you know, their social circumstances, and you don't know where that catalyst for improvement might come from. Could come from any one of those areas. Could be medication, could be talking therapies, could be sorting out some aspect of their social life, and it has a ripple effect on the rest of their life. And actually, if they improve themselves, it can have a ripple effect on their community and their loved ones as well, right? So you can really, it's a domino effect. You can really better society by being a psychiatrist and helping people. And like I said in the talk as well, you know, walking into a room with a suicidal patient, but you know, by the time you left, they're in a better frame of mind. It's just really rewarding for us.
Super, thank you. I think we've probably got time for one more question, which is quite a nice one maybe to end on. If you weren't a psychiatrist, what other specialty would you have picked?
Rachel, do you want to take that one?
I would. So for me, I was always interested in general practice, so working as a GP. But I think if I went back and did it all again and didn't choose psychiatry, and I by no means regret choosing psychiatry, I love my job and I would choose it again. But if I were to do something else, I think probably palliative care would be what I would choose. So working with people at the end of their lives. And they're probably quite linked, really. GP, palliative care, similarities to psychiatry, definitely.
I think if I went back in time, pre-medicine, I might have tried to become a sports star or something, but I probably wouldn't have made it. But honestly, like hand on heart, I can say with psychiatry, you know, there are some challenging days, no doubt, as you'd get in any job. But the fact that you can make such a difference in people's lives, and you can really serve other people and help them, is just so rewarding, and I don't think you get that in any other specialty, and so I wouldn't change that.
Super, thank you. So it is 3 o'clock, so I am going to stop you both there. Thank you both for giving up your time. I'm sure all the students will agree. It was really useful and really insightful. Hopefully lots of you have thought about psychiatry. I just want to very quickly do a little bit of a plug for Medicine Calling, which both Mohammed and Rachel support. Hopefully you can see my slide. So Medicine Calling is a project all around raising the profile of different careers in psychiatry, mental health, for different careers in mental health. And we are running a conference which we hope to run at the University of Leicester, but we're hoping to also have a virtual element on Saturday the 6th of November. It's lots of workshops, talks. I'm sure Mohammed and Rachel will be there, although Mohammed, this date's probably a bit new to you. I only sent it to Rachel this morning. But if you are interested in finding out a bit more about mental health careers, you're interested and want to find out a bit more about psychiatry, you can go on our Medicine Calling website. There's more information about all the different types of psychiatrists, different types of mental health nurses. And if you do want to register your interest in attending Medicine Calling, you can complete a register your interest form. And when applications open, sort of probably end of September time, I will email you the application form. If you're interested in attending, it's completely free for students to attend. It's just another opportunity. Again, something to think about for your interviews, personal statements, everything like that. So can I put the link in the chat? Unfortunately, there isn't the chat, but what I'll try and do is pop it in the Q&A quickly for you all. But let me get that for you. So what I'll do is I'll ask Nick to email it round in the final roundup, so you've got that link to join. So I'll email it over to Nick. So don't worry if you've not got that link. I will put it in your final email later today. So hopefully you'll all agree in thanking our two. So we've already got a thank you so much for that. And yeah, remember 3:30, so half an hour's time, join for the finale session of the summer school, which is an opportunity to say bye to everyone. And yeah, really enjoy the rest of your summer, and really make use of the YouTube playlist, which has got lots of really good resources on there. There's a talk by Rachel on educating for empathy, so give that a bit of a watch as well. And thank you all for your time, and thank you both.
Thank you.
Thank you.
All the best, guys.